Tim Aubrey, whom I've heard a lot of before. I know the name, hadn't met before. He's professor and director and associate dean in the School of Psychology at the university. He's a research chair at the Faculty of Social Sciences and holds the chair in community, mental health, and homelessness. He's the principal investigator in the Housing and Health Transition Study, which is a longitudinal multi-city study investigating the relationship of health status with housing transition. So we're going to learn more about housing. He's done extensive work at the Home and Chez Soi demonstration project, which he'll tell us more about. It's part of the Mental Health Commission of Canada. And Christine Matthew. Christine is a MSc as a research assistant here in Bruyère. And she's working part-time with Vivian Welch and Kevin Cawdy, has a background in aging and health and philosophy. And her research interests are many, but include aging and health and palliative care. So welcome.
Oh, great, thank you, thanks. That's good, yeah. I've worked actually on that project, which we finished now, the multi-site project where we were following people in Ottawa, Toronto, and Vancouver with Stephen Wang. Some of you may know him. He's the overall PI. But what I'm going to talk to you today about was just to set up Christine in terms of talking about this area of related to these clinical guidelines. Every chance I get, I like to talk about this at-home Chez Soi project and Housing First. So, and I think it can just set, some context for the work we're going to do around the clinical guidelines. And this whole issue comes at an interesting time. If you were following the media yesterday, the federal government launched a national housing strategy. We're still trying to figure out how that's going to work. It's over 10 years. It's a $40 billion investment. And we'll see. And it includes a portable housing benefit, which could be very relevant to what I'm going to talk to you today, Housing First. So, I have no conflicts of interest to declare. So the At-Home Chez Soi project, which was launched in 2008, the history of it, just to give you just a little bit of history, just to situate it, I think it came out in 2006, the Senate had done a big study, it's led by Senator Michael Kirby, and there was a local, actually, senator also, it was co-chair, Senator Wilbur Keon, and it was on the issue of mental health care in Canada. And it ended up producing 3 volumes, 3 very large volumes of, there was lots of testimonies and so on. But one of the things that got highlighted in the study when they heard from people across the country was that this relationship between mental illness and homelessness. And it didn't surprise people because you can't be in any city across Canada and not encounter the issue of homelessness. So Michael Kirby, he was able, after that, to leverage from the findings to really set up this project. That at the time it was the Conservative government in power, and they essentially allocated $110 million to do a major project on homelessness and mental illness. And it was quite surprising. I mean, the government was not known for necessarily supporting research, but they certainly stepped up on this particular project. When it got started, the idea was really to see what would be worth looking at as a strategy or an approach to help people who are homeless and have a serious mental illness. Okay? And in large part, I mean, it's often with addictions, and also it's also they also tend to have a lengthy history of homelessness. So what was emerging at the time, it started in the late 1990s in the literature, and then there was some more publications, was this approach called Pathways Housing First. And there were 2 trials that were done in New York City. I remember seeing, the first time I saw a paper, I think it was the late 1990s or early 2000s. I just didn't believe the results. I think it was in the American Journal of Public Health. It just seemed that the effectiveness of an approach that was moving people from homelessness, and a lot of them people who weren't even using shelters in New York City, into their own apartments, it seemed to be too good to be true. Having said that, they continued to publish. George Bush was in the White House at the time in the early 2000s. They took up the approach, HUD, which deals with housing and issues of homelessness in the States. And so when we got this project going, it seemed to be a very promising kind of approach to address homelessness and chronic homelessness, and for this particular population. So that's what we decided to do, is take a look at how could it be adapted and implemented and is ultimately tested in a Canadian context. And it was at the time, because it was a 5-city trial across the country, Moncton, Montreal, Toronto, Winnipeg, and Vancouver. It was going to have over 2,000 people in the trial. It was really the largest study on housing first, and it actually still is. The research lead I'll mention, some of you may have heard of her or know, the late Paula Goring, who did some incredible work over the course of her career in the area of community mental health, and really was one of the early researchers out of CAMH at the University of Toronto, doing research on homelessness and mental illness. So what is the approach? Well, it's not that complicated, actually. There's a housing piece, and the housing piece gets activated with a rent supplement. Okay, so that's a financial support. Okay. Now, it's set at so people are only paying 30% of their income on housing. That's critical, the rent supplement. And then it's combined in the Pathways approach with either a sort of community treatment or intensive case management. Now, in our project, we set intensive case management for people who were considered having moderate needs. You know, when you looked at what type of serious mental disorder they were being diagnosed with, or they'd been diagnosed with, or screened on. And then also a little bit about their hospitalization history, whether or not there was a concurrent disorder, so there was also addictions. And that where we differentiated between moderate level of need and high level of need. And high level of need was the assertive community treatment. Now, you're probably aware of these 2 approaches that do have an evidence base in the community mental health literature.
Can you just be a little more specific about, many of us are clinicians, what is moderate need? Like what diagnoses or degree of severity?
It tended to be depression. It tended to be depression. People who hadn't necessarily had much of a hospitalization history or any hospitalization history in the last 5 months. Last 5 years. They didn't, I'm trying to think if they, there was a whole kind of set of criteria.
Okay, no, but that helps. So it's
Okay,
like hospitalization.
and then a high level need were people with, psychotic disorders. They fell into that area. They had a hospitalization history in the last 5 years, and also this comorbidity was part of it, both in terms of other mental health problems and also addictions. Yeah, so those were the two. So think of housing and either intensive case management or assertive community treatment. So the logic model, so it is housing first. So there's no preconditions to getting into housing. It's not treatment first. So, and what it's replacing is the model of treatment first. Okay? So in this case, people are going into housing with the idea that with a stable house, they'll start to be assisted to get organized around healthcare, around social services. And obviously engagement is part of that. And then longer term, in the mental health field, we talk about the concept of recovery, okay? So recovery means people will still, you know, if you have a serious and persistent mental illness, you'll still possibly have symptoms, but your life is moving along in such a way that you're getting integrated into the community, you're able to pursue things that are important to you, that you want to pursue, and you start to have a better quality of life. Okay, so that's kind of the longer term kind of idea here of housing first. So the project, so this was, as I mentioned, multi-site, randomized controlled trial. We did use mixed methods, and we were interested, because we were testing a Canadian version, there were lots of adaptations. I mean, in Moncton, a small community versus a community like Winnipeg, which 70% of the participants self-identified as being Indigenous. In Toronto, because of the multicultural makeup of the Toronto population, it had to be adapted in that way, working with some of the agencies in Toronto that work with New Canadians, minorities, and so on. We really wanted to unpack the intervention. So this is where some of the qualitative stuff comes in. But we also want to look at outcomes, both quantitatively and qualitatively. So we had a set of measures, and I'll show you that in a second. And then, of course, with this kind of trial, the economic part is important. The issue of cost offsets, cost effectiveness, that becomes part of it. Now, who was in the project? Well, you can see there was good diversity. We had about a third who were women. Lots of health issues, physical health issues. I think that the average was having multiple chronic physical health conditions. 2/3 had a concurrent disorder. And the average lifetime prevalence or time spent homeless was 5 years. So, and I'm only going to give you just a very, with the time I've got, that's just the kind of the big outcomes. There's been about, at this point, I think we're over 120 papers from this trial. So there's lots out there if you're interested. There's also a website, and the NFB was involved. I'll tell you that in a little bit, just about that. But essentially, if we talk about housing outcomes, and that's a primary outcome in this trial, people compared to treatment as usual. Okay, treatment as usual was any other services in the five cities. So compared to treatment as usual, people exited homelessness much more rapidly. So you can see that here. This works. No, it doesn't work very well. But anyhow, the red here is housing first, the upper lines in the 5 cities, and the blue is treatment as usual. Okay. So you can see in the first 6 months, people literally, and these are people who, some of them have been homeless for a number of years, they exited homelessness. If it wasn't for in a matter of weeks, it was certainly in a few months. And then the other thing is there was quite good stability once people were homeless. we talk about in this area a success rate, and this is a 2-year period, of about 80%. Okay? So 80% exit homelessness. Now you can see the gap with treatment as usual. So this is a very, very large effect. And it's there in all 5 cities. Okay, so that's important. The other 2 areas which were also primary outcomes, people did report greater improvements in quality of life across the 1,100 plus people who received Housing First, relative or compared to treatment as usual. And they also were assessed at functioning better. They had greater improvements in what was called community functioning compared to treatment as usual. Now these effects weren't as large as the housing ones, and these were really the 2 main areas. It's interesting when we looked at quality of life, it's in areas, obviously the living situation, finances, leisure activities, those, and safety. Those were the areas. And then if we go to the qualitative findings, this was interesting. These 2 figures, comparing the 2 groups. At 18 months, we interviewed about 200 people. And we wanted to get a sense of how they viewed how their life had changed in a bunch of different areas over the 18-month period. So what we found here, if you look at it, there's, again, there's a difference between the groups. In Housing First, 60% were uniformly positive about how their life had changed in the Housing First group. And this is, when you dig into the interviews, the conversations, they talk about transformation. It's at that level, like this is a different world. I'm now focused on the future rather than just worrying about surviving, because I have a place I can go to that I've got some privacy, I feel safer, and so on and so forth. I've got some goals now in my life, some things I want to try to pursue. And you can see here that it was really only at about 30% for the treatment as usual. Now these people are getting services, and I will say in Canadian cities, we do have other services. The one city that had very little other services was Moncton. But otherwise, you get into the bigger cities. There's lots of different services that are offered out of shelters, transitional housing, other forms of combinations of housing and support. And then just the other thing I'll just mention is the cost, very, very briefly. I don't know if any of you are Malcolm Gladwell fans. Malcolm Gladwell, I think it appeared in the New Yorker here, which was kind of mid-2006 actually. The famous $1 Million Murray article, which policymakers they can cite Michael Gladwell, but they can't cite necessarily any of the literature. But that's why we need these kind of people. But anyhow, the argument that Malcolm Gladwell made was $1 Million Murray was a man in Reno, Nevada, who was on the street, and when they tallied up his health care use over, I can't remember how many years, whether it was 3 years or 4 years, but anyhow, it went over $1 million. Because he was in and out of hospital, he was at the emergency room, he was involved in the justice system, and so on and so forth. So the point Malcolm Gladwell made was, well, if we got people into housing, we could save a lot of money. And that actually drove, there's a discourse out there that these kind of programs, you know, getting people into housing, is going to save you a ton of money. I mean, that's been part of the argument that advocates in the homelessness sector have been taking. But we had a chance to look at this, and the findings are actually more nuanced than that. And it depends when we talk about cost offset. So we costed everything. It was self-report, but you know, economists don't mind doing estimates. They realize that the world is a messy place. So having said that, what we found is people with the highest need who received ACT, you put $1 in of Housing First, you're going to save, there's going to be a reduction of services that's equivalent. Okay, so that's healthcare, social services, justice-related stuff, corrections. Okay. Moderate need, $1 in, Housing First, you give it a third back in the decrease of services. Now, the top 10% in the project, so what we would call the $1 million Murrays in the At Home Chez Soi project, they had actually tallied in the year before they came into the project, they consumed services on average that were worth $225,000. That's very, very significant. If you get those folks into housing, you're gonna get more than a 2-to-1 payoff. So a dollar in Housing First gets a reduction in services. It was about $2.10 or $2.20. So this is where it's a more nuanced thing. Now, if we back up a bit though, what does it cost for one person per year when they were in this project to receive Housing First? Case management, Housing First, $14,000. Okay. ACT, Housing First, $22,000 per person per year. So that's what you're spending to end homelessness for somebody. So, you know, in my books, that's a pretty small amount of money to get people into housing and likely end their homelessness for good. So that, to me, that's the argument that we have to make. Notwithstanding, there are some cost offsets here, but as we know, cost offsets just mean the waiting list gets shorter. I suppose if they were real massive, you might be able to reallocate resources, but that's not usually what happens in the service world. So that's a quick kind of overview of this study. As I said, there's been a lot of analysis that's been done. There's lots of papers available. There is a website, if anybody, and there's a toolkit. We did try to do knowledge mobilization. Mental Health Commission for 3 years was helping communities develop Housing First programs. That's been passed on to the Canadian Alliance to End Homelessness. So we're really in a place now in the country, in Canada, that's scaling up Housing First. It's not without resistance, because any paradigm shift, you know, you're going to get resistance. People like to do what they always do. You know, there was allusion to the battle over this shelter in Vanier. We certainly, and I certainly, try to argue that we really should be looking at Housing First programs. We don't need shelters with long-term beds. We may need shelters, but I don't think providing people residential care is a solution, given what we know. And it's interesting, just to go full circle, the National Housing Strategy, it has set some targets. I think they're ambitious targets. It's over 10 years. There's some disappointment because the money's back-ended, so it's later. In fact, a lot of it won't come till after the next election. But But it is in line with this kind of approach. It includes a portable housing benefit, which would be a rent supplement. So these are interesting times when it comes to housing, and I think what it says is that these clinical guidelines are very timely in terms of targeting people who are homeless. Good, so I'll pass things on to Christine. Thank you.
All right, so I don't know how many of you are familiar with our homeless health guideline project. It's a large project, and there are 3 components. Esther talked about the first part, so the Delphi. The Delphi is used to inform the systematic reviews, which is the second portion. And then the final product is the guideline. So Aubrey talked about how we got from the Delphi to the systematic reviews. And I'm going to try and attempt to explain how we go from the systematic reviews to the guideline. So just this is a slide from the previous presentation. Access to housing came in as top priority for both practitioners and persons with lived experience. Clinical practice guidelines. It's a synthesis of available and relevant research, and it uses a rigorous methodology. And the one that we're going to be using is GRADE. Some of you are familiar with it. It's a system to assess the certainty of the evidence of effects and the strength of recommendations. So we start by formulating a question when we are going from evidence to decision. We make an assessment and then draw conclusions. So scoping the review is the first part. It includes, so when we refine the question, we're talking about the PICO question, which I'll be going to explain the housing component. And then we define and conduct the review, so the main components of doing a systematic review, data extraction, synthesis, and analysis, and then making the review relevant to policy and practice. Looking at the harms, the feasibility, acceptability, and such of the intervention at hand. So for our component, I'm working with Tim on the housing component. This is still up in review. So our population, single adults with mental health problems and addictions, people who are vulnerably housed. Interventions, these are broad categories, so scattered site housing with support, single site housing with on-site support, and transitional housing. Our comparisons, usual care, transitional housing, residential continuum housing, and the outcomes, I categorize them by long-term, intermediate, and proximal. So quality of life and community integration or social participation, we saw as like the long-term goals. Intermediate, the time to exit homelessness, housing stability, satisfaction with housing, participation in employment, education, educational training. And more short-term or proximal outcomes, functioning, mental health, substance use, and cost effectiveness. So when we go from, so we're going to be using an evidence to decision framework, and that's, it enables us to.
I wonder if we can go back to that last slide.
Yeah.
Simone had asked me about this. It's just that this is a lot on this slide, but I think the outcomes is something that often will be really important. And what we haven't done yet in GRADE is we need to put the critical and the important. We haven't actually, like the teams have to rank and put these in order. But you put some outcomes. I don't know if anyone has any comments about. This is the outcomes we probably have already looked and found in some studies already. But there's outcomes you want, and then there's outcomes that you actually will find. It can be a mix.
In terms of comments, I'm not sure that I see. There might be some switching to do between intermediate and proximal, but that's a small thing.
Yeah, we shouldn't even use those.
Well, I use them, but sometimes it's hard to plug them in a category.
Yeah, absolutely.
But I just was thinking empowerment isn't up there yet. And I don't know,
No, there's some of the studies I've looked at.
so like that might be worth, like it's supposed to be almost the face validity of a clinician that's going to trust or not trust. So when you have something that's really important, you have to put it up there, even if you don't find it. And sometimes you just have to report that there was no data.
So I was thinking of empowerment and self-efficacy. Although, functioning might be a consequence of empowerment. So it all, if we had them all up there, and then it depends on what you find, right?
And I think that Simone, I think that the symbol, probably the housing outcomes. It's housing first, so.
Yeah. That's right, that's right.
So we put the housing ones in the front.
Sorry, just a quick question. It's been a couple of years since I last read the at-home Chez Soi stuff, but one thing that stuck out to me at the time was that one of the reasons people left the program or didn't remain housed was that they returned to their social networks from beforehand. And so that stuck with me because I believe, social isolation, quality of social relationships are very important considerations, and understanding the social determinants of health. And I'm just wondering if there might be an opportunity to consider
Absolutely.
sort of quality of social relationships or perceptions of that or something to that degree.
But Casey, I was surprised. I would have thought that would happen, but when they were showing the graphs before, it kind of plateaued, but I didn't see it going down. I didn't see, well, it was only 2 years, but I didn't see people exiting. It was the proportion of people in housing.
But I think you're getting at, and this is pretty consistent in studies, and the French have just completed actually a 4-city trial on housing first and got very similar findings, but there's 15% or so who, for a whole variety of reasons, this type of approach doesn't seem to fit. They don't get out of.
They just don't get out.
Yeah, and what you're getting at is one of the reasons that it's kind of, and people told us about that, detaching from their old social networks. And they would do things like they wouldn't go to the drop-in centers anymore because they didn't want to be around, the temptation of drugs and they were worried about the influence of people who they knew who were still homeless. And then of course, one of the issues around evictions is when people visit and they cause problems in people's apartments and even sometimes take over the apartment. We certainly encountered that.
From the social housing provider's
So-
perspective,
Yeah.
housed through housing first, the formerly homeless, I'm aware of a whole host of issues.
Yeah, no,
that
exactly.
they can encounter, but we don't have to get into all
Yeah,
that.
but I think your
don't
point
get
about the
factored into
social
cost
support,
estimate.
social network stuff, again, it's in some studies.
That's great. Like, this is why we're presenting it, so you can receive feedback and from all your different backgrounds. Yes, so we're hoping to use this framework after we do the systematic review to assess different aspects of the interventions. So we'll be looking at the benefits and harms. It's kind of hard to see, but it says like the certainty of the evidence, the outcome, resource use, so that's when the cost effectiveness comes in, equity, acceptability, and feasibility. I also wanted to highlight a main component of our project is the Community Scholar Program. You got to meet Christine in the previous presentation, and she's been with us since the beginning, and so she's an active participant in our research process. She, along with the other community scholars, will help us to interpret research findings and see if things are acceptable, and provide integrated knowledge translation and exchange. And this is a recent article from the Toronto Star. So Terry Hennigan is our community scholar from Toronto, and he was also in our working group in Montreal, providing input on the housing component. And yes, so looking ahead, at the very end we'll have a scientific panel
I just want to go back a little bit. You don't really have to change the slides, but the other component that we will look at is the qualitative systematic review. And in this qualitative systematic review, we'll look for studies of homeless or vulnerably housed people, and we'll try to understand how they value finding a home. So we'll look for their voices and the key findings, and we'll synthesize from various qualitative studies. We'll also look at the acceptability of different types. We won't be able to do it at the level of quantitative, but we'll get, hopefully, people talking about different types of maybe housing solutions, so that could be interesting. But so these are pieces of evidence that will actually go into our ETD, that big table. So we hope to have, we usually synthesize these into like a quote or two and really try to, and then we can actually look at the confidence behind it, so the grade rating and CERCLAW rating. So that'll be evidence just like the quantitative evidence. So the quantitative is whether it works and how certain we are, and then the qualitative is this voice that complements, I think, our community scholars. So there's a lot of complementary evidence, but we,
yeah. And I guess this is weird because there is a literature on in community mental health on consumer preferences around housing. So it's the preference for housing related to the population. Like, what have they said? And there was just a systematic review that got published in, I think it's ACTA, was it Psychiatrics Scandinavia? So I think that kind of thing could probably help as well.
yeah.
Yes, so we'll have a scientific panel that votes on the different criteria from this table, so the like resource use, acceptability and feasibility. And at the end, we'll re-engage our stakeholders to again look at the feasibility, acceptability, equity, and cost. So now, any further questions? Yes.
Sorry, I was really excited about these two presentations. I do have one more question. And I was thinking kind of a little bit earlier about this. I was wondering if you can clarify for me two things. One is, in terms of the at-home SWAT study, was it a requirement that they be linked with case management in order to participate? Because my understanding is, in Housing First, that the participants would need to self-elect to receive services. I wasn't sure if case management was a piece of that, and if the case management is what you're referring to in terms of housing with supports, because that's the key principle, is it not? Housing First. And I think that's where we get into some of the tricky issues about housing those who may benefit from services, who may never actually elect to receive services, which thus jeopardizes their housing and creates a challenging situation for social housing providers.
So in this project, and it's part of there is a whole area of looking at fidelity of this particular approach. But the deal was the minimum people had to agree to was a 15-minute visit per week. That's it. And they could refuse services. It was not. It's because there's so much premium put on choice and giving. It's kind of part of trying to empower people around their housing, but also around choosing their services. That was the setup. Now, obviously, if you're a case manager and you work with people, you want to develop a relationship. I mean, these programs are very relationship based. You have to have an alliance. You have to have a kind of a trusting relationship with people, and that's kind of early stage stuff. But when we get back to people who it didn't work out for, some of them just didn't engage with support providers, case managers. And I think you have to understand these programs, as successful as this kind of approach is, it's still relatively early in its development. And there's lots of things, and I hope that obviously it's going to evolve. One of the disappointments we had as being involved with this project on the research side was that as good as the housing outcomes were, The other non-housing outcomes, the psychosocial outcomes, they're not, you know, they're very modest, quite frankly. And so I think the support piece, we still need to do work on that, of seeing how can it be a type of support that's going to help people move ahead. And you know, move away from just dealing with crises and look at working with people so they're thinking about the future and they're setting goals and they're pursuing the things that they'd like to pursue, which is kind of the recovery concept I talked about earlier.
I have a question. So I'm
Yeah.
standing here for the air. It's getting really
It is
warm.
hot. It's
I've turned it
I've been
down.
at these meetings,
Yes.
I feel like I'm in hot yoga all the time.
I know. So, you know, one of the things that I've been sort of initiated to recently that I've found really quite helpful is the realist review approach. And so given that there's lots of evidence for this type of approach, we know it works, and maybe it's helpful to understand, you know, on what outcome it promotes. But what about sort of understanding a little bit, like sort of trying to decompose the components of the intervention to understand better what works and where and, you know, for whom and so on. So is that part of, and now as we know that, and that was kind of reinforced, this is not the kind of thing that you find in randomized controlled trials. It's not the kind of information that is published usually in randomized controlled trials, but more in, you know, program evaluations or things like that. So, because if the intent is for recommendation for implementation, that might be sort of beyond just the strength of evidence.
Yeah. I mean, it gets back to the earlier question about the area of mental health and addictions. When you start looking at assertive community treatment and case management, there are studies that compare housing and assertive community treatment and just assertive community treatment, or housing and case management versus just case management. And there's going to be overlap, which we'll have to sort out because of that, I think. But I don't know your thoughts about, you know, the review kind of world, this realist review kind of approach.
Like if I had $1 million, so this has already been brought up, and I think members of the team would like to do this. I see value in realist reviews too, but I mean, with our current funding, we're going to be barely able to do the core elements, but it doesn't mean it will not get done actually. Like I think that, but it does, I think when you could talk to your experience on this too, but I think we're not really going that close to the field, right? So it's very complex when you go down to an actual city or even a part of a city and you're trying to implement something, right? Like that's where the realist review stuff becomes interesting. So I think we're kind of trying to stay a little bit hover up in the helicopter level to try to give a starting thing, like you guys should do this intervention or make sure this is available in your community. But we'll give some discussion and implementation. But I think the realist review element would be really helpful. But it's a bit of a big project, like it would be another big review. So I think, I'm not saying it won't get done, but.
Last comment. I think one of the interesting things to look at might be, and I don't know that this is within the scope of your work, but who delivers the intervention and how it's delivered. And I say this because years ago, decision was made to delink housing from support services. And so therefore, a person wouldn't feel that their participation in supports would in any way impact their retention of housing. And that was great. However, now we have people who are housed, who may benefit from supports, aren't connected to them, and this is a bit of a challenge. And there are all kinds of innovative models that housing providers and other support service agencies, health service agencies, etc., are developing to help with an eviction prevention strategy and the retention of housing and overall promotion of health and well-being. So I would love to see something that actually reviewed the efficacy with which different configurations of intervention are delivered, because I think it makes a big difference.
Yeah, I mean, that's the thing about these reviews. We're limited by the research that's been done. That's kind of the.
And the models are so new, right there.
Yeah, although it's interesting. You're getting at, which we want to look at, and there is a literature on single site what we call single site with on-site support. Unfortunately, there's maybe a couple of studies, they're not great studies, I mean, to start, that compare scattered site with support versus single site with on-site support. That's a question we still need to answer, I think, more conclusively. It's like a lot of kind of areas, but at least it'll be part of what we will certainly look at in this review. It's kind of interesting because Ottawa, it has a fair bit of single site with on-site support. And in fact, the city, I think, probably is, which is the service system manager around the issue of homelessness, they're actually probably biased, that's my view, in that direction. And I'm working as best as I can to push them in the direction of having more scattered site kind of opportunities for people. Because that's what people want. They want to be in their own housing, regular housing. I mean, not everybody, and I think there's a place for a single site kind of option. And there's probably a place to make that option for people where this particular approach doesn't work. So, because it's more structured, there's support right on site, and so on.
Affordable is something that should look at that, I imagine, to kind of push them into.
Well, that's absolutely. That's the hope with that announcement yesterday. Yeah.
Well, thank you very much. Thank you, Kevin, for these guests. It was wonderful.
It's a pleasure.
Yeah, it was wonderful.